Hey everyone, I just did the emphysema breakdown so I can teach it to you guys. And I can't get through all the other topics that you guys voted for because I'm very tired and it's late, so I'll probably try to do them in a different video. Pretty much with pink puffer, or with emphysema, also known as the pink puffer, it's the loss of elasticity in the lung tissue. So the elasticity when things are stretching and something is elastic. So it's the loss of elasticity of the lung tissue and it can cause destruction to the alveoli in the lungs, which can also lead to atelectasis. So ABG finding, if you ever get tested on it, would be respiratory acidosis because of the retention of CO2 because of the obstruction of the alveoli, which means they retain a lot of carbon dioxide in the body and they don't get as much oxygen as needed. And emphysema relies under COPD. So it makes sense as to why they have a low O2 and they have a high carbon dioxide amount. So most clients that have emphysema, they have chronic bronchitis, which is a lifelong bronchi inflammation in the lungs. So, which means they also will probably have a lot of sputum and a lot of mucus built up in the lungs. So they're going to be coughing, crackling, wheezing, all that stuff. So some risk factors would be advanced age. So anytime you get older and you age, your skin loses elasticity. So like the skin doesn't really stretch as much. It gets very thin, gets very fragile, easy to break. So it's the same thing with the muscles in the body. So they lose elasticity in the skin slash tissue, which is in the lung. And then some risk factors would be smoking, which is the most common symptom or risk factor for emphysema is smoking. And they can have a AAT deficiency, which is the alpha antipyricin. Uh, it's like a marker or a protein or something within the body that protects the lungs from damaging. And then another one would be environmental factors, so air pollution, so things in the air that can cause emphysema. So think of smog and secondhand smoke and all those things. Then health promotion would be the most cause of smoking again, so you want to encourage smoking cessation. So like if you ever see a question on ATI or something, it'll say like what should you do as a nurse for someone that smokes and has emphysema. You want to reinforce teaching on smoking cessation and ways and therapies and stuff on to stop smoking. And then you want to avoid secondhand smoke and if someone that knows someone else that smokes around them a lot, you can tell them to use a mask and have proper ventilation. So, you know, air vents and stuff. So then some things that you also want to tell them to do is make sure they get the influenza and the pneumonia immunization because it's very important for people that have COPD in older age. And I like to think of the lungs because since the flu and pneumonia is very common and known, if someone has emphysema, which is a lung issue, and pneumonia and the flu are lung issues, then it's most likely it can be it can compromise their airway pretty much because they already can have chronic bronchitis, so it can just have a lot of buildup of mucus, a lot of exacerbations, and other sorts. So some diagnostic procedures. So you do a PFT, also known as a pulmonary function test. This test is the lung capacity. So pretty much what they do is they sit down on like a chair and they're told to breathe in super fast, take in a deep breath for a certain amount of seconds, blow out for a certain amount of seconds, pretty much just testing the lung capacity. And then they can also get a chest x-ray, which reveals the hyperinflation of the alveoli and flattened diaphragm. So this kind of just checks how dense the area is. And then again, alpha antipyricin levels, which test the risk for lung damage. And then let's see what else. So some expected findings would be chronic dyspnea, so they always have trouble breathing. But that's like so normal in people with COPD because they always have obstructed breathing. So the respirations can reach the 40 to 50 breaths per minute if they have an acute exacerbation. And dyspnea usually happens on exertion, so they breathe in fine, but when they try to breathe out, it's hard for them to breathe out because they have the damage to the alveoli and they have a loss of elasticity. So pretty much it can't really rebound correctly, so they hold in too much CO2. So that's why they have dyspnea on exertion a lot. And then they can have a morning cough and sputum, and then they become they can have hypoxia, they become hypoxic or hypoxemia, because remember the CO2 retention. So if there's a lot of carbon dioxide in the body, there's not a lot of oxygen. Again, so there'll be respiratory acidosis because they have an increase in CO2 and a decrease in O2. And then they can have crackles and wheezing because they can have chronic bronchitis, which is inflammation in the lungs or the bronchi, which also contains a lot of mucus. And then they can have a barrel chest. So barrel chest is when they're like this, it's outward and a little bit in the back too. They have a really thick neck. So here's a little person if you want to zoom in. So they have very thin extremities, so super skinny, and they have a really big chest, and then their neck is their neck muscles are very big. And then hyperresonance on percussion. Hyperresonance on percussion, I don't really know much. I just know that one. And then it'll be due to the trapped air. So yeah. And then they can have cyanosis features, so like clubbing in the nails, which is like thick nails where looks like they have humps on them, and then they can look very pale as well. And then some labs you want to check would be the CBC, the hematocrit, the sputum cultures, and the ABGs. So they'll have increased hematocrit due to the hypoxemia. So I think of saturated. So if there's not a lot of O2 in the blood, and there's a lot of carbon, then it's very saturated. So it would be the increase of hematocrit. And then they have sputum cultures to diagnose acute respiratory infections, CBC for electrolytes, and then ABGs, again, the CO2 will be high, the O2 will be low because they have hypoxemia and respiratory acidosis where they have a retention of CO2. And then let's see what else. Nursing care, I put ABC bitch because you want to make sure you maintain airway at all times. Maximized ventilation would be you want to place them in high Fowlers, which is I think 45 to 90 degrees, pretty sure 90, I don't know. And then you want to encourage them to cough, deep breathe, suction if needed, so they can and splint, so that way they can produce all that morning sputum, all that spit and everything. And then normal O2 sat for people that have emphysema and COPD would be from 88% to 92%. And you never want to increase the oxygen if you see it between this range, because you can actually hyperoxygenate them if they have COPD. So for example, if we saw a test question on an ATI or something, or even on an exam, and it's with the exhibits and the case studies, and it says this patient has respiration rates of 18, but the O2 is at 89 or 91, would you think to increase the respiration rate or the O2 level, or keep it the same and just put them or keep doing what they have to do? So COPD is 88 through 92. And then you want to watch for skin breakdown. Say if they have a via nasal cannula around here and around the ears, you want to watch for skin breakdown. And then for the positive expiratory pressure devices, when exhaling, it should loosen the secretions from the vibration within the device. And you want to promote nutrition, so you want to encourage fluids, most likely 2 liters at least a day. You want to teach diaphragm breathing, so take deep breaths, have them lie on their back with their knees bent, and then place their hand on their stomach. And this is for normal breathing in general. The hand should go in when they're inhalation, thinking you're sucking in, and go out when they're breathing out on exhalation. And then you want to teach them how to use the incentive spirometer, We want to tell them inhale and hold the breath for 3 to 5 seconds during inhalation. That's just another way to like test for lung capacity. And there's another one, it's like a peak flow meter. It's kind of the same thing, but you kind of just test the lung capacity with that too. And then client education would be encourage 2 liters of fluids daily. They can have 4 to 6 meals a day. You want to make sure they take the medication regimen, no smoking, and there's other client educations, but it's like common sense ones. Those are like the biggest things. Then over here is the medications. So bronchodilators. So in a case, an event where, let's say there's like an asthma attack or like some type of acute exacerbation or something, you want to use a short acting beta 2 agonist, which is albuterol, which can cause tremors, but that's usually the first line of treatment for those type of attacks. And then the long-acting beta 2 antagonist would be the ipratropium, which is kind of like a anticholinergic. It's one of the cholinergics, and they can get a dry mouth, so you want to make sure you look out for dry mouth and I think canker sores. And then the methylxanthine is the theophylline. So this one I think is one of the last resorts because it can be very toxic and cause a lot of palpitations. And then corticosteroids would be, we use that to reduce inflammation. Same thing with montelukast, the cromolyn, and the monocol. So you want to watch for hyperglycemia, fluid retention, and weight gain in canker sores. And then mucolytic agents. So pretty much they take this to thin out the mucus so it can be able to help clear up so they can spit up more and splint. And then one thing you want to tell them to report is black tar stools and blood in the GI. And this is emphysema. Yay.